lung function. So it really drops your lung function quite a bit and causes, in that context, your functional status to potentially deteriorate, and in some situations, patients to be left with a functional status that would be very difficult to maintain their quality of life and potentially require oxygen. And obviously that's one of the things that we try to avoid by selecting patients appropriately when we decide what surgical procedure they are subjected to, is that we actually really try to preserve quality of life as best as possible and preserve lung function as much as possible with these surgical procedures, and try to do this in a proactive fashion where we actually try to select the right candidates for the right surgical procedure up front. Because in contrast to extrapleural pneumonectomy, pleurectomy and decortication, the competing surgical strategy is designed to preserve the lung, and therefore patients actually typically end up with more lung function at the end of the procedure. But I think it's important to recognize that it is a dramatic change. That being said, typically if you have healthy lungs, one lung actually can provide pretty good function for a patient. As is actually an example for that is when we perform lung transplantations. In patients with end-stage lung disease, we actually frequently only transplant one lung, and patients can gain decent lung function after a single lung transplant.
Dr. Sturman, following an extrapleural pneumonectomy, if you develop a pleural effusion, how safe is it to insert a Pleurex catheter for draining those infusions at home?
Are you talking about on the side where the pneumonectomy was done?
No,
or the
I'm talking about the
opposite
contralateral side when the disease
I think
returns.
it's very safe. I mean, you have to use ultrasound to guide those procedures. And I think as long as you're using ultrasound